Thank you, Cindy. Well, I'm very humbled to be here with you all, especially with my fellow colleagues that are presenting, because they're the true experts. As Cindy pointed out, the Hogg Foundation and myself, we've really been promoting integrated healthcare, and so we're very happy to be involved in this endeavor, because as you'll see through my talk, I'm a bit passionate about it, and I think that's truly the future. I think that it makes me think of Charles Dickens a bit. It's the best of times, it's the worst of times. Especially as you're thinking about the transformation of healthcare that's happening. It's truly a tremendous transformation that's occurring. And so Cindy asked that as part of the class that we actually taught together, my talk was sort of giving context and overviews. So that's what I'm going to do for you today, and really leave for the rest of my colleagues. They're going to really drill down and give it some more specifics about integrated healthcare and what's happening in their specific realms of the world and how they're influencing and making changes that I think are really just tremendous. No conflicts of interest or declaration. So here are some trends, right? So most of you, I hope, are aware of these, but if they're not, it doesn't hurt to actually, reflect upon these and take a look at them. Often we see, I'm going to give you a bit of statistics with these trends, and often people just see the numbers. But what I want you to really think about, and I challenge you, is to think about an individual that you know, either a person, a friend, a family member, someone in your community who's dealing with mental illness, or substance use, or any other type of physical ailment, chronic or acute, and put it within the context of what these trends and numbers really mean for each and every one of us. So take a look at that first bullet, right? So we know that the diversity of America is changing very quickly, especially now as it's accelerating. 2050 seemed like a long time away when the statistics were first came out, but it doesn't seem all that far away anymore, especially as you see how things are changing for our youth. And they're changing very quickly. Not too far from now, everything's going to be flipping in the interest of diversity. And I think that diversity in and of itself, in fact, is actually a gem that we really need to sort of utilize to the maximum, in the sense that diversity is truly, to me, a really key component of how we actually can improve and actually achieve excellence in our healthcare system if we utilize it and recognize it properly. How about since 2011? What's been going on with the baby boomer generation? Now, what I find interesting about this statistic, and in some of the national meetings that I'm at, and we're talking about what we need to do from a workforce standpoint, and also from how do we change our curriculum in reference to our institutions of higher education, especially those that are dealing with the healthcare professions, is like, we didn't know this wasn't coming, guys. Come on. Since the day they were born, the baby boomer generation has been changing the face of America, and it's no different now that they've hit the age of 65 at the rate of 10,000 a day now since 2011. So think about the implications not only for our society, how we're actually going to deliver that care for them, the cost that is going to come along with that, and how it's actually going to impact as well our workforce, and I'm talking about just employment in general. Because by 2020, which is only about 16 years away, the majority of folks that are going to be working are going to be over the age of 55. Compared to today, 25%, 1 out of every 4. That's pretty tremendous. How are our private institutions, our public institutions, all those that are employing us, because that's going to be us, how are they going to handle the health care? And obviously, the status quo is untenable. The status quo is definitely fractured, it's siloed, hence the reason that many folks here, especially those of my colleagues that have been working at this for decades, have been trying to change the paradigm. So healthcare consumes almost 18% of GDP. We can't sustain that, especially if we want to maintain our be globally competitive. Because all of us really know that if you're not healthy, if you don't have a healthy society, it's going to be really difficult, in fact, to maintain that competitive edge, nationally as well as internationally. So let's switch to the state of mental health. 1 out of every 4, we've heard that statistic very often. Like I challenged you, I want you to really think about that and try to make it a personal issue. Let's not just leave it as a statistic, especially for today, when we're all together and really thinking about some of those challenges that Dr. Carlson laid out for us, to really be thinking about how are we going to change what we're doing going forward. Obviously, it's affecting our kiddos. 20%, 1 out of every 5, also are dealing with a mental illness at any one time in any given year. Now, that third bullet, what that tells me, though, is that, number one, we need to be moving, and hopefully all of us are thinking about that, toward prevention. We really need to get on board early. And not in just the life of the child that may be affected or is at risk, but in fact, we need to go earlier than that. We really need to start thinking about our young individuals that are thinking about starting a family or in those ages when they can start a family, even if it's planned or unplanned. Because the impact that can happen during gestation is so important of what happens to the development of especially the central nervous system. We need to be on board and be helping them to understand the implications of what we do today has long-term implications. The ACE study, there's lots of studies out there that address those very issues. And of course, if we don't address these things, we can see there in the next bullet about untreated mental illness, what ends up happening? We've already seen it. And it's extremely costly for every state and for the entire nation, especially the fact that now really the incarceration of the mentally ill is at an all-time high. As a matter of fact, if you look at the National Sheriff's Association study, and they've already done actually their second rendition of that just came out earlier this year, we are at the rate of incarceration that was back in the 1890s, during the time of Dorothea Dix, when she actually had the movement to, in fact, bring in institutional care, which at that time was an advancement, taking people out of the incarcerated areas and let's move them into a more humane setting. Now, that changed over time, as many of us are all aware, and then we went to the community health movement and so forth. And we're in a transformation as it is now again. But it's a U-curve. The rates that folks were being incarcerated back in the 1890s, we made great progress, and now we're back at that same rate. People have been using the terminology that which institutions, in fact, are providing the greatest mental health? Harris County Jail in Harris County in Houston, Texas. Cook County up in Chicago. LA County out in California. That is just, to me, just hard to even imagine. And we use the term that they're providing mental health care, but the truth is we know that that's not really the case. They're having huge challenges in trying to take care of the populations that they're dealing with that have been incarcerated and are not providing the best of care. That is not the setting that you want to actually provide mental health care. They don't have the resources, the infrastructure, they don't have the workforce, and they sure as heck don't even have the budget. So, it gives us something to really pause and to think about. How are we going to change that? And it's extremely costly. We're a capitalist society, have been since our inception. So think about that last bullet, $105 billion estimated cost, and that's mostly just about depression and anxiety as it results in absenteeism and in presentism. I have a little trouble with that one. But basically, you're at work, but you're not fully functional because you're dealing with issues of either depression, anxiety, or both, or other issues. And so this is an issue that affects all across the board. It doesn't matter which part of our system or our sector of society. Mental health knows no bounds, especially mental illness as well. Well, I personally think that we are at a crisis point. The statistics tell me so. Take a look around. Some of the traumatic events that have happened, unfortunately, across the nation and up in Fort Hood brings really down and drills it down to home for most of us. But my goodness, it's now the 10th leading cause of death. In 2009, it surpassed deaths from motor vehicle accidents. More than 38,000 suicides a year. Folks, that's more than 100 individuals a day that we're losing. Which of us would say it's okay to see a jumbo jet go down every week in the United States? Because that's what's happening. If we really put those statistics and kind of look at them in a different form and fashion. Think of all the people that you know. Each of every one of us, I'm sure, has a network, and we can think of 100 people. Imagine if they were just taken off the planet. What are we going to do? Now, if that doesn't capture your attention, you're really saying, well, that's the civilian workforce. Well, obviously, we've been in conflict now for over a decade, so we have a lot of new veterans. We still have our veterans from the Vietnam era, and a few from the World War II era. But those veterans are still suffering, going all the way back, and now we have new ones, and especially now because of technology. Many individuals that would not have survived a conflict are in fact now, and so now we're seeing a lot of traumatic brain injury. That's really gone out the roof. But were we prepared for it? Did we know we were going into the conflict? Yes. Did we gear up the VA system to handle it? No. Illogical. Why? And now we're losing 22 veterans a day. And that last bullet was really telling to me in 2012, for the first time ever, as far as I know, and according to CDC statistics, my goodness, suicides in active duty personnel exceeded those being lost in combat. So as you can see, there is no area that is not untouched by mental illness. So let's switch gears and let's take a look at some what's going on in general for the U.S. population. 34 million American adults, 17%. So really the 17%, because the 34 million comes from a bit about a decade ago, but the statistics haven't really changed all that much. How many folks are actually who have mental illness are also dealing with physical illnesses? Very large percentage. And the same thing is happening, obviously, with those that are dealing with chronic illnesses or physical illness, and how many of those are dealing with mental illness. And so the Venn diagram, it's really that sweet spot in the middle. And that's where integrated care can really, in my opinion, make quite a bit of a difference. Well, what about what's going on in the population, databases that we do have, where we can really bring big numbers together? Medicaid. Well, we know that Medicaid finances more than a quarter of the nation's spending for behavioral health care. So it's definitely a system that we definitely want to pay a great deal of attention to because of the number of dollars that are involved. And for many of you, I know you're aware, it's the largest single source of funding for public mental health, behavioral health dollars. And when we take a look at the data there, the same thing happens that we're seeing obviously in general for the entire population, which is that the majority of folks that are dealing with mental illness are also dealing with chronic illness in the Medicaid population. And here you can see that the big three are diabetes, cardiovascular disease, and pulmonary disease. So these are very significant chronic illnesses that are affecting our populations. Now, taking this from Kate, has been modified, and I agree with the tenor and the concept, the tenet and the concept of this diagram, because it is very complicated. And as you can see, there are social determinants and risk factors that are influencing. The only thing that I would sort of change a bit is that I would take quality of life out of the adverse health behaviors and outcomes, because it is an important outcome, but in my opinion is the most important outcome, and I would move it outside the box and say that, in fact, that's where we want things to lead to, is actually improved quality of life. But it really sets the stage for what we're talking about today, and the complications that exist and how they interrelate and interact. Hence the reason, back to integration. Let's get rid of those silos that we created, and let's really, in fact, look at things from a much more holistic standpoint. Well, if morbidity isn't your game, how about mortality? Yeah? Because, man, there's some really interesting statistics there too, right? Excess mortality. Take a look at this study that was done, and the increased relative risk if you have one of these mental illnesses and what it does to your lifespan. Personality disorder, my goodness, that's 4 times. Very significant. So where does that leave us with the reality of care, as I call it? Well, as we know, the majority of us really like to just go to our primary care doc. I flew in from Albuquerque yesterday. I'm in Dallas, and from Dallas to Austin, I'm with an individual sitting to my left. Elderly gentleman, he's got a couple more years still before he says he wants to retire. That's what I was doing. Unfortunately, I told him, and then find out a psychiatrist, and so it was time to actually put my shingle back out and listen to his woes. But I don't mind, because I get to learn so much, and it's a privilege to hear about what's going on in someone's life. And so he's telling me how difficult it is to access the system. Now, he's 63. He's going to be 65 in a couple of years, but what he's really dealing with and worried is his elderly parents, and in fact, also his in-laws. And they're having a tremendous trouble trying to access services and trying to coordinate services. It ought not to be that way. He told me the same thing. Why can't I just go to my doc, and why can't they just sort of coordinate everything? Because we go here, and then we're going over to the cardiologist, and then we got to go to the rheumatologist, and then I found the rheumatologist and talk to the cardiologist, and they're prescribing medications that the other one has prescribed as well, and then some different ones, and I don't know what we're supposed to give my mother-in-law, because the last time we gave her medications, she went loopy on us. Those are real issues that are affecting real people, and that's where integrated care, in my opinion, can make a big difference. And as you can see, primary care is where the majority of psychiatric conditions are showing up anyway. our primary care colleagues out there, be they family practitioners or internists, general internists, or pediatricians, they're hurting. They need assistance. They need resources. And if you take a look at certain populations, what we call populations of color, racial and ethnic categories, same thing. We want to go and just see the primary care doctor as well. We feel more comfortable there. And we know that there are many issues of why that is, but one of them is stigma. And we still have a lot of work to do when it comes to the stigma of mental illness. Now, this study really caught my attention by Pham and his colleagues. In 2009, it was published. What was really interesting to me about this was it's the first time that I'd actually seen a study that sort of showed what is happening to our primary care docs. They are seriously overwhelmed. For every 100, and they looked at Medicare. Once again, it's a good database, so therefore that's where they really could tease things out, and they really can take a look at what was going on. But for every 100 Medicare patients, imagine this, a doctor, a primary care doc, is going to have to interact with 99 other physicians in 53 different practices. Now, each and every one of us, think about if we had to do that in our daily life. Now, if you're not going to get overwhelmed, I really would like to meet you. And I'd like to find out, boy, what are your resiliency factors? What resources do you have? Because my goodness, I know I would be. And it resonates with me. When I was doing clinical practice, a lot of times you're just on the phone trying to get a hold of somebody. You're on the phone trying to coordinate, why didn't I get that fax on that EKG, and I need it now. And in a single year, a typical primary care doc coordinates care with 229 other physicians working in 117 different practices. That's the course of a year. Anyway, to me, these were just really eye-opening statistics. And obviously, we're talking about a very new concept, right? No, we're not. My goodness, folks. We knew about the mind and the body and the spirit long ago. We lost our way a little bit along the way. But luckily, I think there's now a trend, there's definitely a movement to bring it all back together. Socrates knew about it. Now, I'm not going to read this to you because integrated care, it's on there. I think everybody's got the handouts handed to them. But there are some really key words in here that I think are extremely important for us. One of them is team. Working together. Systematic. Cost-effective approach. Patient-centered. And each and every one of us should be asking, what exactly does that mean? Because that's where it helps us to have that dialogue, to really tease it apart, to truly understand, are we on the same page? Well, one of the things the Hogg Foundation did, and I think that it was really something really important for us, we partnered with the Office of Minority Health, because what we saw was integrated health care. There's this body of knowledge that was being created and moving forward. Cultural linguistic competency had also had this body of knowledge. But not enough folks, it seemed to us, were really talking about, once again, that Venn diagram where they come together. So we wanted to bring experts from across the field out in the field, folks that really had exemplars of doing things like Cherokee Health System. Perinda was one of our consensus members. And they really came together, and it was a real eye-opening. The report's out there, and there's the link if you would like to go see it, which I really encourage you to do, to really understand how cultural and linguistic issues truly are important. Don't forget the trends that's happening, the diversity of America. And remember, it's not just about racial and ethnic folks, because all of us have race and ethnicity to some extent, in my opinion. This is about all of us. And if we don't deal and learn to deal with the different individuals, families, and communities out there, then how, in fact, can we actually be patient-centered, in my opinion? So for patient-centeredness, cultural and linguistic issues are front and center. Key components, I'm not going to read all these through, but just highlight them. Obviously, the team approach that we mentioned. But my colleagues, I think, will be able to highlight that even better. The patient-centeredness, which is so important. Population focus. There are some key components to integrated healthcare that we have found that integrity to the model is really important because it really gets you to where it is you want to go, which is in improving the health and the outcomes of your population and your community. Stepped care, flexibility, being able to go step up and step down. Care management functions, very key. Now, a lot of these are meeting challenges, in effect, are we able to get them reimbursed? But I tell you one thing, we're in the middle of transformation, so we don't have all the answers now. But changes are in the wind, and they will need to happen. And we need to, each and every one of you as a leader, and I challenge you to go out there and start saying, well, why haven't we made that change? What are we waiting for? We know where we need to go. Let's do it. And obviously, we need to be outcomes-based. Have good metrics. Not a ton of metrics that overwhelms the system, but in fact, just a few metrics that we can hang our hat on and go, that's what actually is helping us to achieve the goal. So in my opinion, it truly is a paradigm shift. Now, I want to key on really the paradigm shift of thinking about from cultural linguistic competency, because I really think it is very key to being patient-centered. So, when you're taking a look at organizations or externally, or if you are within the organization, you're part of it, are you in fact making sure your administrative policies, job descriptions when you post them, reviews, performance, your practices, your workflow, are you thinking in a cultural and linguistically sort of centered approach to it? That's what we need to be doing. Now, there's other approaches that we need to incorporate in that as well, but that one is the one that I'm challenging you on today. If you don't know how to do it, establish what we call a change team. How about doing this? How about with not the usual cast of characters, but how about bringing in some of the community, some of your actual consumers? Remember, they only play a role as a patient. That does not define them. But let's bring them in. The resources and the answers are out there. If we're willing to step out of our comfort zones and bring them in on board to be able to help us to come up with the solutions that we need. Because it's important to be able to change expectations, to change the culture that we've created. It's in the midst of change, and so for some of us, there's a lot of turmoil. But you know what? I think that's okay. Disruptive innovation is what's going to get us down the road. Relational coordination theory. I bring this to your attention because I think this is where roles where psychology can really play a big difference. Because psychologists, they have that viewpoint, they understand human behavior, they understand how systems interact. And yet, that's exactly what our organizations need. Sometimes we're very good at the clinical level, but we forget about the middle management, administration, the executive level. Are they on board? Are they being supportive? Are their policies all in tune? I've been historically in clinical organizations where we at the docs were there trying to make changes. Our medical director wasn't on board, didn't want to hear about it. You don't get very far when you have that lack of support. So what are some key attributes that supports the highest level of coordination to really lead to outstanding performance? You need to have shared goals, shared knowledge, and by God, mutual respect for each other. Everybody on a team has something to contribute. It doesn't matter if it's a certified peer specialist, which is an individual with lived experience who is now part of your team, or it's the guy with the big M.D. and the Ph.D. We've got to be able to even the playing field. Let us all rise to the best of our knowledge and what we can contribute and be able to really then interface together and make it a difference. But we've got to be all on the same page. So what reinforces that? Communication is probably one of the most important things that we do as human beings. And yet how often we say, oh, we miscommunicated. I didn't know what you meant. Because we don't take the time to really understand communication and realize some of these things are important. Timeliness, frequency, accuracy of the communication, and especially in organizations, making sure that you're focusing on the problem and not on the distractors. And this takes someone with skill. It is something that is learned and it's something that has to be reinforced and maintained, like any good skill. And that's where psychology, I feel, can really make a difference. Because the whole point is outcome, a coordinated collective action, in this case, the integrated healthcare. This is the model that we came up with from our consensus report, the one that I referred to earlier, cultural linguistic competency and bringing integrated healthcare together. And what we came up with was the ICO, the Integrated Care Organization. And what is an ICO in our opinion from that report? Well, the ICO, in fact, is not in the community, it is part of the community. And it's part of a learning community created by them with other systems and organizations that are part of their community. Very important for them to be doing that. An organization that understands social determinants, an organization that in fact understands what's happening to their community. Because if you're able to do that, then you're able to really move into the realm of what's really affecting my patients and what's really impacting them and resulting in the dysfunctions or the reasons they're coming to your clinic. because they're coming to us for a reason, because they see us as experts or they see us as having the resources to help them. One of the things that we envisioned, obviously, and hopefully, is that, in fact, it's coordinated. So from an IT standpoint, as well as when a clinical history is taken, that same one clinical history will be used by the entire team, an integrated team, a multidisciplinary team, and yet a team that's respectful and that follows all the guidelines that I laid out before. And a team that, in fact, is moving all toward the same goal, which is what? What we would all want for us, for our children, for our families, for our neighbors, a good health outcome. How often and how many clinics out there in healthcare organizations are really working toward that? That's what we should question. That's what we should be pushing. That's what we should be demanding. Why? Because I think reasons to incorporate cultural and linguistic appropriate services is really where it's at. Why? Because it's going to respond to the projected demographic and current changes that are happening. I believe that it will, in fact, lead to decreased health disparities if we're able to achieve this in the appropriate fashion and all of us working together. And it achieves the triple aim. Dr. Don Berwick has been talking about the triple aim for quite a bit. It makes sense. But I tell you, we will not achieve the triple aim, in my opinion, if we do not have cultural and linguistically centered integrated healthcare approach. Because that seems to me really gets to eliminating stigma, gets us to really start thinking about prevention, and really allows us then to address truly, holistically, what folks are coming to see us about. And it's the future of the healthcare in America, in my opinion. Why? Because it respects the whole person across their entire lifespan. That's another thing we need to be thinking about, is the entire lifespan. It includes prevention, early intervention, as I mentioned. Strength-based, trauma-informed, recovery-focused, achieves health equity. Because in essence, I think our organization is going to be person, family, and community-centered. Maybe I'm a pie-in-the-sky kind of guy, but I don't think so. And I'm going to keep pushing until we get it done. Thank you very much. Back.
Do people have questions?
Because I don't want to answer any questions that either Perindo or Sandy
Questions, discussion?
can answer, but
Okay.
yes.
And there was a question.
Oh, you want folks to use the mics to
We were
Sandy,
told to
because-
use the mic. So.
for recording purposes. Yeah, that makes sense.
Thank you for that presentation. I just had a question about, on one of the slides, it said something about working in defined or really specific populations, and I was wondering if you could speak a little bit more about that.
Working in defined or specific populations, I think what's interesting about integrated healthcare, it lends itself very well to be looking at specific populations. For instance, there's some folks we call the dual eligibles. It's usually a very good example, which is individuals that meet the criteria for Medicaid and Medicare. And so they have a tendency to be very high utilizers as well, which is another group or population that you could define. But what integrated healthcare allows you to do, in my opinion, if that's where an organization, say, wants to start, is either in the high utilizers or maybe then their dual eligibles, which we know use up a lot of resources, and then bringing the resources together and helping them to really have a really collective effort from our standpoint, and working with them to become truly an activated patient, as we call them, someone who's really engaged. But it takes work and it takes some time. That's the other thing that I didn't address, but is self-evident. Hopefully it's self-evident, but not so much to our policy stakeholders. Sometimes we have to explain to them, it takes time to make these changes. You know, we can't expect that we're going to just implement some of these resources and methodologies and then in 6 months everything's done. Sometimes it takes much longer than that. But if we take somebody who's, say, a high utilizer and is going to the emergency room quite a bit, say an individual with diabetes, but also have major depression and maybe some anxiety issues, and we're actually then able to find out what are the risk factors that they're dealing with, what are some of the other issues that are affecting. I think the other thing that integrated healthcare allows one to do is to really go after other issues which unfortunately have been sort of siloed off. What is happening from a transportation standpoint? I still remember a case that I had where there was this elderly lady who showed up late to her appointments and was labeled as non-compliant. Let me tell you, for those of you clinicians, once they put that in your chart, you can't get it out of there. I mean, they won't let you. It's just terrible. But she lived on one side of town, and she had to take 2 bus passes. She would take the bus to come to the clinic. She didn't have any control on the traffic or if the bus broke down, and yet she's being labeled non-compliant, so she showed up an hour or 2 late. Well, I took her into as part of my cohort of patients that I want to take care of because I said, that's not right. But there's ways that you can define how you want to make that defined population. It's really in leaving it to the clinic or to the organization to kind of come up with that, their own rubric, and then that way they can track and over the course of time see how the outcomes and the metrics changing and seeing if they're going in the right direction.
That's
Good.
so much more clear, yeah.
Oh,
Thank
thanks.
you.
Good question, though.
So something that I think that we've both struggled with is there's so few metrics around measurement for kids and adolescents about what's successful and what works, especially in these programs. And that's something that I think we continue to struggle with. So I'm curious your comments about that because there's so much more on adult. And then there's certain things that are easier to measure in adults, like their hemoglobin A1C and their blood pressure. But with kids and adolescents, we really struggle with how showing these integrated programs work.
No, I think you're right on about that, and I don't have an answer for that yet, other than we're looking at it as well, and we're trying to find out who out there maybe has, has been able to achieve that or has an example that we can maybe take to scale. But there's questions out there that we still don't have the answers to, but those are the very questions we need to be asking, and hopefully it'll get us down that to the right pathway to be able to answer that. But I'm not there yet. Any more questions?
Other questions?
I know I couldn't have answered all your questions. Hopefully I left you with a bunch of questions to really that you're thinking about, because I think that's the whole idea about today is to really be thoughtful and critical.
Okay. Thank you.
Thank you.